Okay, everybody, welcome to our final video, not only of this series, but in this class, and we're talking about pulmonary hypertension. So, a big subject that we need to be able to understand. We need to know why it's worse than your typical garden variety systemic hypertension, why it affects our patient's heart and lungs, why it makes them short of breath, what we can do about it, all those different things. So just in short, I'm sure you guys have already read this, but unlike systemic hypertension, which is commonly encountered and can exist for years before we start to see, real hardcore consequences from it, pulmonary hypertension carries a much poorer prognosis, with many patients dying within 5 years without proper treatment. Now that's fast. You guys probably have either known somebody or do know somebody, whether or not they've shared it with you, but they've probably had hypertension for longer than 5 years or maybe even decades. And while like we've said, that's not healthy, that's not desirable at all. There's a reason that pulmonary hypertension is so much more deadly. This dim outlook is primarily due to the fact that increased pulmonary pressures have a huge effect on the right side of the heart, because like we said in previous videos, the right heart was never designed, it never evolved to encounter a lot of resistance and have to generate lots of pressure, because it's used to just pumping blood through the lungs, which compared to systemic circulation is incredibly easy. You don't need very much pressure at all. There's very little resistance at baseline in the pulmonary circulation, so that right heart just doesn't have to be strong and big and buff. And then all of a sudden, if we ask too much of that right heart, it's very realistic that it will not be able to keep up with that, and it will fail, and it tends to fail very quickly once this process takes off. Again, because it was just never designed to pump against a large amount of pressure and resistance. So right heart failure develops along with the disruption in gas exchange, which results in an even more rapid decline. So let's get into some particulars here. There's actually 5 specific types of pulmonary hypertension. That term pulmonary hypertension is just describing high blood pressure in the pulmonary circulation. Now, most examples that I've given or talked about are talking about pulmonary arterial hypertension. So high blood pressure in the pulmonary arteries specifically, but realistically, any kind of backup anywhere in the pulmonary circulation will cause the pressures to increase, and that qualifies as pulmonary hypertension. So let's cover these real quick. You guys can zoom in on this picture over here on the right hand side and you'll get a little bit more detail. It's just giving you a whole bunch of different causes of these specific types of pulmonary hypertension and the potential treatments. And as you might imagine, if it's a different thing that causes your pulmonary hypertension, then it's going to be a different thing that fixes it. So that's just the whole idea of having the right tool for the job. Again, you guys will hear me say that a lot of the time. You're going to be working against yourself, wasting time, money, and energy if you're trying to treat something utilizing the wrong method or the wrong tool. Just like, you can't tighten a bolt with a screwdriver and you can't drive a screw with a socket wrench. You have to, it might be a very straightforward thing that you're trying to do, but if you have the wrong tool for the job, then you're not going to be able to get it done. So, knowing all our different diseases, and if there's subtypes of those diseases, we got to know what those are so they can be treated appropriately. So anyway, pulmonary arterial hypertension, they also abbreviate that PAH. Pulmonary hypertension due to left heart disease, we should understand that, because we know that if the left heart fails for any reason and fluid starts to back up into the lungs, that's going to increase the pressure. So that's a different subtype of pulmonary hypertension. Pulmonary hypertension due to lung disease and or hypoxia, we talked about that too. The hypoxia part in particular having everything to do with that hypoxic vasoconstriction. So if you missed out on the whole hypoxic vasoconstriction discussion when we were talking about right heart failure, you might want to go back and review that, because this is one of those things that we had mentioned, pulmonary hypertension being one of them. And also hypoxic vasoconstriction placing an enormous workload on the right side of the heart. So patients who have chronic lung disease that leads to chronic hypoxia, or another reason could just be maybe they live at altitude, so they don't have lung disease, but they are chronically hypoxic, so they chronically have hypoxic vasoconstriction and chronically strain the right side of their heart. Another one, category 4, that's chronic thromboembolic pulmonary hypertension, abbreviated CTEPH. That's also a very fun subject to talk about, which will come up in later classes. I think either on this slide or the next one. Let me look. It's probably the next one. I threw a couple links to some YouTube videos in there that are They're basically just short little videos that explain this very special surgery that they do for patients with CTEPH specifically. And it's kind of fun to talk about. You'll hear me talk about it, and it'll come up in other classes from time to time because that specialized surgery, the PTE or the pulmonary thromboendarterectomy, was a surgery that was developed right here in San Diego at UCSD back in the 70s. So basically, UCSD invented all the cutting edge diagnostic and treatment methods that hospitals around the world use to treat CTEPH. And there's only a few of them. I mean, it's maybe like a half dozen or so, maybe a couple more than that, but it's very, very small. The number is, it's definitely in the high single digits or low double digits of places worldwide that perform that particular surgery. And it all got started at UCSD. Right here in San Diego. So something that we'll talk about later on for sure, but that relates specifically to chronic thromboembolic pulmonary hypertension. And then category 5, this is kind of like the catch-all category, pulmonary hypertension with unclear multifactorial mechanisms. So it could be a whole bunch of other things, like we recognize stuff like sarcoidosis, blood clotting disorders, different kinds of metabolic diseases and things like that. So at the end of the day, all pulmonary hypertensive, but 5 distinct different flavors or versions of pulmonary hypertension, all with distinctly different treatments. So signs and symptoms of pulmonary hypertension. Well, you're going to recognize a lot of these from our right heart failure video because this pulmonary hypertension is stressing the right heart. So we see a lot of signs and symptoms of right heart failure. So a lot of this will seem like I'm repeating myself, and it's all due to the backup of fluid. So it can be difficult to differentiate, at least at first, between all the different types of right heart failure, all the different causes, and just straight up pulmonary hypertension without more invasive hemodynamic information. So I promise you, when it gets to that point, when we're talking about really sick, critical patients and it comes time for hemodynamics, we will talk about all that stuff. What are the exact ways we differentiate between all these different things? How can we diagnose valve problems versus dilated or hypertrophic myopathies versus chronic blood clots, acute blood clots, measure all these intracardiac and vascular pressures. It's really cool. So I promise you it's all coming up. Along with patient history, during our assessment, we're gonna look out for things like JVD. We already described that. Those jugular veins bulging out from the backup of fluid, peripheral or dependent edema, again from the backup of fluid, hypoxemia for a couple of different reasons, which I'm going to draw out here in a second. Shortness of breath, of course, especially on exertion, because this patient's right heart isn't functioning and they're not adequately supplying their gas exchange surface with enough blood because it's right heart failure. And then right-sided cardiomegaly as this gets worse and worse on the chest x-ray. And of course, cyanosis if that hypoxemia is bad enough, and digital clubbing, because like we've talked about before, that digital clubbing results from prolonged periods of hypoxemia. So just real quick on why the dyspnea, why the hypoxemia, let's just go back to our classic gas exchange unit. So that's what it should be normally. But then if we shrink this down, so let's shrink down this blood vessel and let's say it's only this wide. So they've got vasoconstriction for whatever reason. Makes a really good example. Of course, that constriction right there, if blood is only flowing through this little area, of course that's going to raise the pressure in the pulmonary arteries and strain the heart. But look at that. That is a significantly lower amount of blood passing this AC membrane, and the little bit of blood that does go past that AC membrane, because that blood vessel is so small, it just goes rocketing past there super quickly, and there isn't a whole lot of time for O2 to diffuse and equilibrate, so they have horrible gas exchange as a result. So there's lots of things going on that are contributing to their shortness of breath. This right here, the disruption of gas exchange, is likely to be one of them. But also, as that right side fails, it just makes this whole problem worse, because now you have a failing heart that has to pump through all these tiny little blood vessels. So the VQ mismatching is just, it's getting worse and worse and worse, along with all the other side effects that we see from the strain on the right side. And then our last slide here, well, second to last, I should say. Treatment of pulmonary hypertension involves dilating the pulmonary blood vessels, restoring effective pumping action of the right side of the heart. So maybe it's one of these, maybe it's a combination of these. So inotropes, we already know what those are. Make that right side of the heart beat harder, not necessarily faster. Make it beat with more force so it can push blood through the pulmonary vasculature. Diuretics to control fluid balance. So always remember, heart failure, hearts hate fluid. Whether it's right-sided or left-sided, hearts that are failing do not like to deal with extra fluid. So heart failure, hearts hate fluid. We got to have just enough to keep things running. You don't want any excess fluid with patients with any kind of heart failure. So diuretics help ease the burden of that heart by controlling their fluid balance, making it so they don't hold on to too much. Oxygen therapy, of course, because this patient's probably going to have disrupted gas exchange at some point, particularly if this pulmonary hypertension is caused by hypoxic vasoconstriction. We had mentioned that in a previous video. If we know that this patient has some sort of lung problem where they are chronically hypoxic, that's chronically causing hypoxic vasoconstriction, raising the pulmonary pressure and stressing the right side of the heart, well, why not give them some oxygen and help reverse that? So in some cases, it's not that straightforward. Oxygen, especially in severe pulmonary hypertension, it gets to the point where oxygen is going to have a minimal effect on the on that hypoxic vasoconstriction action. But nonetheless, the supplemental oxygen will inevitably help increase O2 delivery. Even if it's a little bit, it will increase the O2 delivery. So oxygen therapy for sure. The same vasodilators that the patient is a candidate for with right heart failure. So we're going to want vasodilators that specifically dilate the pulmonary vascular bed. A lot of the other ones that we use to treat like left heart failure, those don't act the way we want them to or at all on pulmonary vasculature. They work out in systemic vasculature. So make sure we have those squared away. Pulmonary hypertension is one of the things that can qualify a patient for a lung transplant as long as they are a surgical candidate and they're able to be matched. And then we mentioned that fancy surgery, the pulmonary thromboendarterectomy, also known as PTE surgery for CTEPH. That was category 4. In our 5 different types of pulmonary hypertension. And here we go. This is what I was talking about. These are the little YouTube links for you guys to visit later. We'll talk about this cool surgery and that disease process in future classes, but just so you guys got cool extra stuff to watch, that's what we're talking about. And it may not sound very complicated right now. Oh, they can go in and pull clots out of the arteries. But just think how inaccessible pulmonary arteries are, how deep they are in the chest, and how difficult it must be for somebody to go in there and open up each one of those little pulmonary arteries and dig out clots and be able to safely reconnect everything and have the patient still survive the surgery. That's part of what makes that surgery so fascinating. So anyway, that's like I said, very similar to our treatments for right heart failure, just targeting pulmonary hypertension specifically. So just a quick review, what you're going to need to make sure you have sorted out in your head before you move on to bigger and better things. If these diseases impact the lung tissue itself, the airways, the chest wall, or the neuromuscular function, then how is it possible that they impair gas exchange and oxygen delivery to the tissues if, like we just said, all the respiratory drive and ability to expand the lungs and everything is intact? Why can that happen? Let's make sure we know the difference between right and left heart failure, difference between diastolic and systolic heart failure, what those terms mean, dilated versus hypertrophic, cardiomyopathies, different types of valve diseases, just real generic with the arrhythmias for now. We'll get more detailed later on. Don't forget our vascular problems such as MIs, PEs, and pulmonary hypertension. And think too, don't let it slip your mind how blood composition plays into this. So what do I mean by blood composition, and why would blood composition at all play at all into things like PEs, MIs, and pulmonary hypertension, or even just regular hypertension? Just things to start quizzing your brain, start getting that in-depth understanding. So that does it. That's our final video, our final category, our final video checkpoint for this course. So hope you guys enjoyed.